So I am presenting two abstracts from a single meta-analysis on the topic that is the pride of every medical oncologist, PAT-CR. So the abstract one is re-evaluation of PAT-CR as a surrogate of EFS and OS in HER2-positive early breast cancer patients treated with neoadjuvant therapy, including anti-HER2 therapy. So PAT-CR has prognostic importance. It is frequently used as a primary endpoint. And in 2012, US FDA accepted PAT-CR as a surrogate to support accelerated approval of new drugs. This was done with the intention of finishing the studies faster as compared to their adjuvant therapy counterparts, so as to give the benefit to the patients sooner. The current evidence is that it is a strong patient-level surrogate, but can it replace EFS and OS as a primary endpoint in HER2-positive breast cancers? So this was the primary objective, to correlate PAT-CR with long-term outcomes, EFS and OS, both at patient level as well as the trial level, considering intention to treat population of the available RCTs. So eligible RCTs were identified. There were a set of 11 RCTs, which at least had 100 patients and had at least a follow-up of 3 years. Primary objective was to correlate YP, T0, TIS, N0, and long-term outcomes EFS and OS, both at patient level and the trial level. And the secondary objective was to do it in a more stringent definition, YP, T0, N0. So this is the consort. The patients who did not undergo surgery were considered not to have a PAT-CR. So this meta-analysis used a two-level modeling approach to associate PAT-CR with EFS and OS. So at the patient level, the strength of association was quantified using a Plackett copula, which gave an odds ratio. And that odds ratio indicated the risk of EFS defining or OS defining events if there were more than one. At the trial level, linear regression were fitted through the treatment effects on PAT-CR. So data was available for 3,980 patients with a median follow-up of 61 months for the EFS and 62 months for the OS. HR for EFS and OS was 0.42 and 0.34 respectively, favoring the group of patients who had a PAT-CR. This strong patient-level association was corroborated with the ORs from the copula model, and they were both more than one. However, the trial-level associations were weak. So here you can see that for patient-level association, the ORs were more than one, but for trial-level association, the treatment effect of PAT-CR on EFS-OS were weak in all cases, and most 95% confidence intervals were too wide to be informative. Interestingly, the associations at patient level were stronger for the OS as compared to the EFS. So the authors concluded that PAT-CR cannot be used as a trial-level surrogate for either EFS or OS in future trials in neoadjuvant treatment of operable HER2-positive breast cancer. Nevertheless, because of its important prognostic role, PAT-CR remains a patient-level surrogate that can guide patient management and continue to be used as an informative endpoint in itself in this setting. So at the patient levels, a surrogacy is quite proven, but there's a disconnect between patient level and the trial level surrogacy. So because there's a heterogeneity in the design of RCTs which were used in this meta-analysis, there could be different treatment regimes used in the neoadjuvant period as well as in the post-op period. Unfortunately, this possibility cannot be formally assessed in this work, and even in the presence of PAT-CR, we cannot take the treatment as a valid endpoint of EFS or OS benefit. So like other tumor-based endpoints, PAT-CR should not be a good surrogate for long-term outcomes when you talk about any neoadjuvant treatment. So this, although at the patient level, it is strongly associated with EFS and PS, but these findings preclude the validation as a surrogate for EFS and OS. And it does have a prognostic effect, but it should not be used as a predictive term for new treatments on either EFS or OS in the future trials. So the second abstract is again coming from the same meta-analysis, another publication, PAT-CR and individual patient prognosis after neoadjuvant therapy plus chemotherapy plus HER2 targeted therapy for HER2 positive early breast cancer. So achievement of PAT-CR is strongly prognostic of EFS and OS in patients who have early breast cancer. The rationale of this study was to characterize the prognostic role of PAT-CR, taking into account the other prognostic factors like tumor stage, nodal involvement, and hormonal status. So this present analysis, again, like the previous one, it's from patients from 11 NACT trials who had more than 100 patients and had available data for at least more than 3 years. The individual prognostic role of selected variables was investigated in univariate analysis, clinical T size, and nodal status, hormonal receptor status, and PAT-CR in itself. So both EFS and OS, with or without the characteristics of interest in different categories of variables, were selected, and they were compared between the groups using the Kaplan-Meier curves. So the median age was 49 for the entire cohort, 3,710 patients available for analysis. Clinically stage 0 was there in 35% of the patients, and 54% were hormone receptor positive. So out of these 1,497 patients, 40% had PAT-CR and 59.6% had a residual disease after NACT. So PAT-CR happened more often in patients with T1, T2 tumors, absence of nodal metastasis, and hormone-negative disease. The patients experiencing a PAT-CR were at lower risk of recurrence or death regarding EFS and had a significantly better OS. In patients who had a PAT-CR, clinical stage T1, T2 versus T3, T4, and N0 versus N1, they're independent prognostic factors for EFS, but only clinical T stage was significantly prognostic for OS. By contrast, the clinical T size, clinical N status, hormone receptor status were independent prognostic factor for EFS as well as OS in patients without a PAT-CR. So the authors concluded that in patients with residual disease after neoadjuvant therapy, hormone receptor status was of utmost importance regarding the 5-year EFS in patients of all subgroups defined by clinical T size as well as clinical N stage, with worse outcome for patients who had hormone receptor negative disease. For those who were hormone receptor positive and had a residual disease, had better prognosis if they were T1, 2 node positive, and a worse outcome was observed for T3, T4 N positive disease. Hormone receptor negative T3, T4 N negative tumors at diagnosis had and a residual disease resulted in 59.1% of EFS rate, while primary nodal involvement led to the decline in EFS to 45%, which marks the worst outcome in the entire cohort of patients who were HER positive. So as reported by EFS, hormone receptor negative EBC with residual disease after neoadjuvant therapy also had a worse outcome concerning the OS. So this combined study could not only confirm PAT-CR as a predictor of a patient outcome, but moreover identified the first time risk factors for long-term outcomes, both in the subgroup of patients with and without PAT-CR. So all patients do well after PAT-CRs and suggest that efforts to identify patients at risk in need for an escalated treatment approach are worthwhile. To further redefine this identification, a prognostic score consisting of the number of risk factors present should be developed and demonstrated that patients with higher number of risk factors, regardless of the PAT-CR, would be having a significantly worse EFS and OS. So this simple scoring system could help clinicians for concerning treatment outcomes after neoadjuvant therapy. The take-home message is that in patients with residual disease, clinico-pathological risk factors higher tumor stage, nodal involvement, and hormone negative status could be confirmed as an independent prognostic factor for EFS and OS. By contrast, the patients with PAT-CR after neoadjuvant systemic treatment, only tumor stage and nodal involvement were prognostic for EFS, and this were further restricted to tumor stage concerning OS. Thank you.